Okay, let's unpack this. Imagine a group of people, often working tirelessly, often completely unseen, providing essential care day in, day out for their loved ones.
Hmm. They're really the backbone of so many health systems.
Exactly. But what happens when they desperately need a break? And maybe more importantly, do they even want one?
That's a really critical question.
Welcome to the deep dive. Today, we're plunging into a crucial yet often sort of overlooked aspect of healthcare,
Yeah.
understanding how informal caregivers really feel about respite care.
Yeah, what are their actual attitudes?
Precisely. This deep dive is based on a fascinating study using something called Q methodology. It's from the journal Health Policy back in 2007 by Van Exel and colleagues.
A really insightful piece of work.
It really is. They meticulously investigated caregivers' perspectives. So our mission today is to uncover the nuanced, maybe even surprising viewpoints caregivers hold about taking a break, getting support.
Moving beyond just simple assumptions.
Right. To give you a clearer, more empathetic understanding of this vital, almost invisible workforce. So we're talking about these unsung heroes, the informal caregivers. And globally, we're leaning on them more and more. It's becoming a huge reliance.
It really is. And the Dutch context, which this study focuses on, is a perfect example. You've got budget constraints in healthcare, right?
Yep.
Plus, a rising demand for care overall. And, most patients really prefer to receive care in their own homes if possible.
Which all puts immense pressure back onto families, onto these informal caregivers.
Exactly. And the scale is just, well, it's kind of mind-blowing. In the Netherlands alone, you've got about 6% of the population, that's 1 million people, spending more than 8 hours a week caring for a loved one.
8 hours minimum.
Minimum, and often for more than 3 months straight. Now get this, that number, 1 million informal caregivers, actually equals the total number of people employed in the entire Dutch healthcare system.
Wow. Okay, that puts it in perspective.
It does, and it's 6 times the number of professional home care workers. It's this huge, indispensable contribution, but, often completely unrecognized.
And while their dedication is incredible, this role definitely comes at a cost. The burden, the sheer weight of caregiving can have a profound impact on their daily lives.
Oh, absolutely.
Yeah.
A substantial burden. Many caregivers are really struggling to keep it up, sustainably, alongside everything else, work, family, their own lives.
It's not just feeling a bit tired, is it?
No, not at all.
Oh.
The risks are significant. We're talking about physical problems, emotional burnout, social isolation, financial strain.
Mm-hmm.
And for older caregivers, that strain can even lead to increased health problems, higher morbidity, even mortality rates. It demands immense resilience, often at a really severe personal cost.
So given that kind of profound burden, this idea of respite care becomes, well, not just helpful, but essential, really.
Definitely essential.
And for anyone maybe not familiar, respite care is kind of a general term, right, for different ways to support caregivers.
That's right. It covers various interventions designed specifically to give caregivers a break. The goal is to temporarily reduce their burden, help them recharge, restore their ability to cope.
And what does that look like in practice?
Well, it comes in many forms. It could be support groups, where caregivers share experiences and advice.
Right.
Or information and counseling from professionals. Special holiday arrangements sometimes that give everyone a break. Daycare programs are common.
Where the person receiving care spends time outside the home.
Exactly. Or even in-home respite, where someone comes in temporarily to take over the caregiving tasks. So quite a diverse range of options trying to meet different needs.
And these programs, they actually work, don't they? The effectiveness is pretty well established.
Yes, widely recognized. They've been shown time and again to alleviate that caregiver burden, help prevent those negative health effects we talked about.
Mm-hmm.
And interestingly, they can even increase a caregiver's willingness and ability to continue providing care in the long run, sustainably. Plus, it lets them pursue other things, maintain a bit of their own life.
It really sounds like a win-win situation. Good for the caregiver, good for the person receiving care because the care can continue.
Indeed. It's a vital tool for long-term sustainability in caregiving.
Yeah.
But, and this is the big but,
Yeah.
this raises that important question we started with. If respite care is so vital, so effective, why isn't it universally embraced? Why isn't it used more?
Why do we see so many caregivers clearly struggling, but not actually accessing this proven support?
Exactly. And that gap is precisely what this study we're diving into aimed to understand by looking directly at the caregiver's own attitudes. What do they think?
Which brings us to the study's approach, because they didn't just do a standard survey, which might give you averages but miss the nuances. They used something called Q methodology.
Right.
Can you break that down for us? How does it help get at those deeper attitudes?
Certainly. Q methodology is, well, it's a really powerful tool specifically for studying subjectivity. It gets at people's viewpoints, their beliefs, feelings, opinions, the why behind their answers.
Okay, not just what they think, but the pattern of their thinking.
Precisely. So instead of traditional surveys aiming to generalize about huge populations, Q methodology focuses on identifying distinct, shared viewpoints within a smaller, often carefully chosen group. It reveals the different ways people think about a topic, not just the average response.
So how did they actually do it with the caregivers in this study?
So in this specific study, the researchers gave caregivers a set of 39 statements. These covered things like their motivations for caregiving, the burdens they felt, and their specific attitudes towards respite care.
Okay.
Then the caregivers had to sort these statements. They arranged them into a specific pattern, kind of like a pyramid or bell curve, from most like my view at one end to least like my view at the other.
So they're forced to make choices about what's most important to them.
Exactly. They can't just agree with everything. They have to prioritize. And crucially, afterwards, they also explained why they sorted the statements the way they did, often in writing or an interview.
Ah, so you get the quantitative sorting and the qualitative reasoning behind it.
That's the richness of it. That combination is what makes Q methodology so insightful. It allowed the researchers here to really peel back the layers, challenge those simple assumptions we talked about.
Yeah, let them see distinct groups of caregivers, right? Not just averages, but actual types of attitudes. That seems critical for understanding why some seek help and others don't.
Absolutely. It gets beyond the averages to the real diversity of experience.
Okay, so the big reveal. The study identified 3 distinct groups of caregivers based on their Q sorts, each with pretty unique needs and perceptions about respite care. Let's unpack the first one. Group 1. Need and ask for respite care.
Right, so this group is perhaps the one you'd most expect to be actively seeking help. They strongly experience a substantial burden from caregiving. They rated statements like, informal care is associated with a great deal of stress, very highly.
Okay, so the burden is clear to them.
Very clear. And they also seem burdened by social isolation, agreeing with things like feeling they've missed out on their social life because of caregiving tasks.
That makes sense.
And crucially, they indicated they would not mind if someone else took over their caregiving tasks sometimes. They strongly disagreed with the idea that they didn't want to hand over responsibility.
So they feel the strain, they recognize they need help, and they're actually open to receiving it. What's the holdup then? Why aren't they getting the respite they seem to need and want?
Well, this is where it gets frustrating for them. Despite that clear need and openness, they often feel misunderstood and undervalued by the official channels, health organizations, welfare organizations, even the specific informal care support centers.
Really? So the support system isn't connecting with them?
It seems not, from their perspective. They rated statements about satisfaction with assistance from these places quite low. What they do want, what they express a need for, is practical, empathetic support, like just having a ready ear to listen, assistance with practical questions, navigating paperwork, dealing with problems. And they explicitly say they would like to make use of things like in-home respite or daycare services.
But there's a catch.
There is. Interestingly, even though they want this help, they also agreed with the statement, I find it difficult to ask for assistance when I feel I need it.
Wow. So needing it, wanting it, being open to it, but still finding it hard to actually ask and feeling unheard when they try, that's a tough spot.
It's a real contradiction.
Yeah.
They're also less likely than other groups to see caregiving as inherently enjoyable or purely their duty. They're doing it, but the burden is outweighing the satisfaction.
Did the study give any hints about who tends to fall into this group? Any demographic patterns?
It did offer some tentative insights, yeah. These caregivers tended to have a longer history of caregiving, were more often caring for someone with psychological health problems, reported a higher subjective sense of burden, and tended to have lower levels of education.
Okay.
They also reported being less happy overall and receiving less support from other informal caregivers, like family or friends. But again, the study stresses these are tentative links, really hypotheses for more research.
Understood. But it paints a picture. So if you're listening and this resonates, if you feel this way or you know a caregiver who does, well, you're definitely not alone. This group is out there asking for help, But hitting these barriers, feeling unrecognized, finding it hard to ask, maybe not finding the right kind of practical support.
That captures it well.
Okay, let's move to the second group identified, group 2. Need but won't ask for respite care. Now this one sounds even more complex, almost contradictory.
It really is. This group is in a very difficult, sort of paradoxical position. On the one hand, they do derive satisfaction from caring for their loved one. They rated statements like, caregiving makes me feel good, positively.
Okay, so there's a positive aspect for them.
Yes, but it's also associated with a great deal of stress. They agreed strongly with that statement too, just like group 1.
So satisfaction and high stress.
Exactly. And here's the core conflict. They indicate they would actually like to hand over their caregiving tasks sometimes. They disagreed with the idea of not wanting someone else to take over.
Okay, so similar to group 1 in that respect.
Yes, but, and this is the crucial difference, and often a hidden barrier, they also strongly indicated that the care recipient, the person they're caring for, does not want to be cared for by anyone else.
Ah. So the resistance isn't coming from the caregiver themselves, but from the person needing care.
Precisely. And that, for them, makes asking for assistance a huge problem. It creates this immense internal conflict between their own needs and the perceived wishes or demands of their loved one.
Wow, okay. That's where it gets incredibly nuanced and difficult. They're caught in the middle, burdened, maybe wanting a break, but facing direct resistance from the person they're trying to help. That's a really complex emotional landscape.
It truly is. And you see other things that fit this picture. They tend to value feelings of control, perhaps feeling they're the only one who can do the care right.
Mm-hmm.
They often appear to have their tasks quite well organized on the surface, maybe not needing help with practicalities as much as group 1. But underneath, they find it really difficult to draw boundaries, to stand up for their own needs.
So managing the logistics, but struggling with the emotional load and the boundaries.
Exactly. And adding to that, they feel more strongly than other groups that their wider circle of acquaintances, friends, other family just leaves the caregiving task entirely up to them.
So a lack of external support potentially compounding that internal struggle.
It certainly seems that way. Tentatively, again, these caregivers were more often not employed, perhaps because caregiving took over, more often caring for a partner or a parent, reported lower self-assessed health, and expressed more concern about the future.
That paints a picture of someone really carrying a heavy load, often quite alone, trying to balance their own well-being with the complex demands of the situation, especially that resistance from the care recipient. A very challenging position.
Extremely challenging.
Okay, finally, let's look at group 3. Do not need respite care. Now, on the surface, this sounds like the ideal scenario, maybe. The caregivers who are managing well.
Yes, that's generally the picture. These caregivers appear to have a much more balanced caregiving situation overall. They ranked many of the statements about strain, feeling overwhelmed, physical strain, feeling depressed, very low.
So, genuinely less burden?
It seems so. And they actively enjoy the caregiving process. They rated, caregiving makes me feel good, very highly, even more so than group 2.
Mm-hmm.
But interestingly, they also strongly see it as their duty.
So it's both fulfilling and an obligation they accept.
Exactly. A combination of genuine satisfaction and a deep sense of commitment.
So what's their secret sauce? What helps them maintain this balance where the others struggle?
Well, a strong support network seems absolutely key for this group. They rank the statement, my circle of acquaintances leaves the caregiving tasks entirely to me, very low. They feel supported.
Ah, so the opposite of group 2 in that respect.
Precisely. And they also deeply appreciate it when people in their network show concern, ask how they're doing. That recognition matters.
And are they able to ask for help if they do need it, even if they generally feel balanced?
Yes, that's another key point. They strongly agreed with the statement, I don't mind asking for help when I need it. So that barrier to asking isn't there for them in the same way.
Okay.
Now, that's not to say it's all perfect. They did sometimes indicate experiencing financial and practical problems, and like many people, might find application procedures for formal assistance a bit hindering or bureaucratic.
Sure.
But these issues don't seem to throw their overall situation off balance to the same extent as they do for the other groups.
So even for this group that seems to be managing well, there are still valuable lessons, particularly around the power of that strong support network, feeling appreciated, and just having the capacity and willingness to ask for help when needed. It underlines how important those external factors are.
Absolutely. The social context makes a huge difference.
And any tentative demographic hints for this group?
Yeah, a few patterns emerged, again, needing more research. They tended to be younger, reported being happier, or less likely to live with the care recipient.
Oh, interesting. Living separately might create some natural distance or boundary.
Possibly. They also less often performed extensive household tasks as part of their caregiving, and crucially, reported having more support from other informal caregivers as well. So maybe sharing the load more.
Right. So a picture of a more supported, perhaps less intensely enmeshed caregiving experience overall.
That seems to be the pattern, yes.
Okay, so we have these three distinct viewpoints. How do we connect this back to the bigger picture, maybe to policy or how support services should work?
Well, if we connect these findings, the study really backs up the idea that the fundamental need for respite care is pretty directly linked to how burdened a caregiver feels. Higher burden generally equals higher need.
Makes sense.
However, and this is the key takeaway, the actual demand for respite, whether someone actively seeks it out or accepts it, can be seriously impeded by these other factors we've discussed. It's not a simple equation of need equals demand.
Right. And those impeding factors are different for the groups who need support but aren't getting it, groups 1 and 2.
Exactly. For group 2, the big one is the care recipient resistance. Their loved one doesn't want anyone else. That's a deeply personal relational barrier.
A very sensitive issue to navigate.
Extremely. For group 1, it seems to be more about a mismatch, a lack of compatibility between what they need and what's being offered or how it's being offered.
So like information problems, not knowing what's available, or communication issues.
Could be. Or the services offered just don't quite fit their specific, often very practical needs. They want help, they're asking in their own way, but the system isn't quite hearing them or delivering what they actually require. They feel unrecognized in their plea.
So this really highlights the need for a more targeted approach, doesn't it? Rather than just assuming all caregivers need the same thing or face the same barriers.
Absolutely. A one-size-fits-all approach clearly isn't going to work. The study strongly suggests that groups 1 and 2 are the primary targets for respite care interventions, as they have the highest unmet needs.
Okay, so how should support be tailored? For group 1, the ones who need help are open to it, but feel unheard and struggle to ask.
For them, the focus really needs to be on better communication, on genuinely acknowledging their efforts and their struggles, and crucially, tailoring services to match the needs they state.
What might that tailoring look like? More flexible options?
It could mean different ways of providing information, perhaps more proactive outreach, maybe more flexible scheduling for in-home support, or daycare that fits around other commitments. It might mean support centers taking a more active, personalized approach to really understand and respond to their specific practical needs and their feelings of being undervalued.
Okay, making the system meet them where they are.
Yeah.
And what about group 2? The ones caught between their own stress and the care recipient's resistance. That sounds much tougher.
It definitely is more complex. For group 2, any effective effort has to involve both the caregiver and the care recipient. You can't just focus on the caregiver.
Right, because the recipient is the barrier.
Exactly. The goal has to be gently, empathetically trying to convince both of them that using some form of respite care is actually in their mutual interest, that it's necessary to make the caregiving sustainable in the long run, preventing burnout for the caregiver, which ultimately benefits the recipient too.
How do you even begin to tackle that resistance from the person needing care?
It's delicate. This study floated ideas like maybe introducing acquaintance days for potential home care providers or daycare facilities.
Like a trial run?
Sort of. A low-pressure way for the care recipient to slowly get used to the idea, meet potential alternative caregivers, see the facility, without feeling forced into it immediately. It's about building trust, overcoming that initial fear or reluctance, and showing them it could be okay, maybe even beneficial, easing the transition, demonstrating mutual benefit.
That makes a lot of sense, a gradual approach.
Now, just before we wrap up, it's worth quickly mentioning a couple of nuances about this study, just to keep the findings in context.
Okay, the usual caveats with research.
Exactly. Firstly, remember it used a convenience sample. These were caregivers who had already sought out informal care support centers.
Right, so they might already be feeling more strain than the average caregiver out there, the ones who haven't sought any help at all.
Precisely. So the findings might reflect the needs of more strained caregivers, and we might even be missing the perspectives of those who are so overwhelmed they can't even make it to a support center.
Good point.
And secondly, Q methodology, while fantastic for revealing these shared viewpoints, the types of attitudes, it doesn't tell us the proportion of the general caregiver population that falls into each group.
So we know what these three attitudes look like, but we don't know if group 1 is 10% or 40% of all caregivers out there.
Exactly. We understand the what, not necessarily the how many.
And finally, those demographic links we discuss, who tends to be in each group, the study emphasizes those are tentative at best.
So more like strong clues or hypotheses for future research. That's the right way to see them. They point towards areas where larger scale research could really dig deeper to confirm those patterns.
Okay, that's helpful context. But even with those caveats, the core message seems incredibly powerful.
I think so.
What's truly fascinating here, what really stands out, is that informal caregivers are just not a monolithic group. You can't paint them all with the same brush.
Definitely not.
Their needs, their motivations, the barriers they face in accepting help, it's all incredibly diverse and deeply personal. This study really makes you think about those hidden complexities of caregiving. It gets way beyond that simplistic idea that, if someone needs help, they'll just ask for it, and if help is offered, they'll just take it.
It's rarely that simple.
So what does this all mean for you, listening? Well, maybe next time you encounter a caregiver, or perhaps if you're reflecting on your own situation or someone you know, you could consider which of these perspectives might be at play. Is this someone feeling unheard but needing practical help? Group 1. Someone caught in that difficult bind with a resistant loved one? Group 2. Or someone who seems okay but relies heavily on their network? Group 3.
Thinking about it through these lenses could make a difference.
Yeah, how might understanding these distinct attitudes change the way you offer support or advocate for better services, or even just how you engage in a conversation? How can you have a conversation that truly meets someone where they actually are, acknowledging their specific reality? It's a powerful insight, I think, into a world that often remains unseen but touches so many lives.